Next speaker is from Budapest, Dr. Gábor Hermann from Semmelweis University. Dr. Gábor present paradigm shift in orthodontics. Please, Gábor.
Okay. Thank you for the invitation, and let me just grab my screen. So thank you very much for the invitation again, and sorry for losing some time. And just let me get in and start the presentation from that point. Paradigm shift comes with understanding of the need of paradigm shift. So I would like to step back and use this quote and just look at what we call orthodontics from a different perspective. And many years ago, this TED talk made a huge impression on me. It was this person is called Simon Sinek, and the presentation is called the Golden Circles, and it was really impressive and fantastic to me, and it helps to understand everything in my life. So this method I use for my personal development, for my business, for my practice, for my treatments. And it's a very simple approach. So if we do something, do we know why we started to do this and how we apply the knowledge to achieve the final outcome, the practice, what we do. So I try to use this analytic mind in the upcoming couple of minutes in my presentation. And I use it because definitely we can say the long history of orthodontics has given beautiful smiles to patients and people all over the world. And using all the tools what we have at the moment, we can say we are specialists of what. So we have seasoned beautiful appliances, tools, microimplants, three-dimensional planning, three-dimensional appliances. So we are perfectionists on how to put a tooth from one position to another, how to put the jaws from one position to another. So we are specialists of what. But in order to get answers from ongoing and never-ending debates, I would like to step back and use filters to ask again the whys. So this is how I structure my lecture today. I would like to get into the problem first. Maybe you find it a little bit provocative, and then I will build up why I think a new paradigm is necessary in the orthodontic specialty. So when we go to the, in order to understand, like I would say differently. So in order to understand if there is a problem, I would like to ask you just put the perspective into the patient's perspective. So if there is a patient in the age of evidence-based medicine, and there is a profession which has 120 years of age, so we expect that, so when we try to imagine something like 120 years old, so this is a old professor, just a Buddhism monk, or a beautiful library, old university, and library with beautiful books, with all the knowledge. But concluding, so there, the perspective, from the perspective of the patient, we believe that there is a codex. There is a big book contains all the knowledge specified to every problem that can happen in the orthodontic specialty. And this is exactly how a patient believes that this profession is based or founded by. And when the patient goes to a specialist, we expect that I have a different specific problem, so there can be an answer in this codex for that specific problem. So if it is really true, so we need to get back and analyze the definition of the orthodontics. And when we look at the definition, we will find that we move teeth and bones, we treat formations that are called malformations, jaw malformations, or dental malocclusions. And we can specify based on the practice that we deal with local issues. We look at these kind of problems like isolated, and mainly we use as a problem cause the genetic inheritance. And when we look at the malocclusion, we look at this as a potential pathology. So these are the three principles that specify or qualify the current contemporary orthodontic specialty. But if we go deep in, let's say, 6 steps, and we just try to dig into the perspectives or the qualifications of the orthodontic specialty, first we should talk about the phenomenon called evidence-based orthodontics. And the movement started back 10 years ago, more than 10 years ago. And by this time, or at this time, even we thought that we are very close to say this is an evidence-based profession, this is evidence-based science. But when it comes to the everyday situations, and we are just faced by a situation like this, overjet, class 2 malocclusion, and then it seems that there is a big debate on how to approach. So one orthodontist will say this is an extraction orthodontics of the maxillary, premaxillary premolars, or surgery, or distalization, or clastoelastics, or non-extraction by moving the jaw forward with either type of alternative approach. So there is a big serial mixture of different kind of opportunities, and it is an ongoing debate, very similar to the early treatments and all the other ongoing debates in the orthodontic specialty. And it seems like instead of professional evidence, we form groups. So there are academic schools led by different professors, and there are going to be distalizers, extractionists, non-extractionists. So it is like fans of different clubs and groups. So we are fighting with each other with ideas instead of saying which is evidence-based or which is not evidence-based. But when it comes to the evidence-based question, I would like to get back a little bit, because by the definition of the medicine in general, we say medicine is formed by understanding of the etiology, formed by diagnostics, and then the treatment comes. So before we start collecting evidences about how to retract teeth in an extraction and how to distalize teeth, which method is better than the other, but we have to get back and ask if the diagnostics and the diagnosis itself and the etiology is really evidence-based. And I still use this book because so far this was the only that tried to collect the actual evidence-based information about the orthodontics. But I have to say there is no even a chapter about diagnostics and etiology of orthodontics. So how can we talk about evidence-based orthodontics if there is no evidence-based information about how the formation of the problem started, and how should we diagnose it on an evidence-based manner? So this is a big question to me. How can we talk about evidence-based medicine if there is no answer for whys and hows? And if you go back to the second approach, let's look at the contemporary diagnostics. So the contemporary diagnostics is based on the local phenomenon. So we say the orthodontic malformation, the jaw malformation is not in a relationship to the surrounding part of the or the total human body. And we form these kind of diagnostics to achieve stable results. But when it comes to the reality, we know that based on Bob Litter's investigations, nothing is stable. So we have to put patients on lifelong retention. We go further and we try to understand again these kind of features like local, genetic, and pathology. But again, so what do we treat? We treat malformations, and most ideally, if there is something called mal, there should be a definition of norm. Of course, on an anatomical way, we can describe norm, but what really norm is? So, does angle one relationship prevent temporal and joint disorders? Does angle class 1 prevent periodontal problems or speech problems? And vice versa. So if there is a class 2, is it really obligatory to have consequences later on? So the problem is that there is no information about the norm is protective or preventive to any potential problem. So malocclusion is not really a pathology. So the question is, why do we use this kind of classification? Of course, from the aesthetic perspective, there is an explanation, but from the functional perspective, we are lacking the information that would support that class 1 is the ultimate goal from the functional perspective. And when we go to the risk management perspective, from the ethical and medical legal perspective, the do not harm principle of medicine is that if there is a problem, and in our case it is malocclusion or malformation, and there is a potential treatment, of course the treatment should not bring more harm and more risk to the patient than the lack of the treatment. And we cannot say, because if we are not able to support that malocclusion is a pathology, and we contrast it with potential risk of tooth extraction and orthodontic surgery, so certainly the risk-benefit ratio is going to be a little bit disturbing. So this will bring that the intervention itself has a higher risk to the health of the patient than the lack of the treatment. And what do we say about multifactorial origin? And I ask it because still in the profession, many colleagues, I would say, still this is the majority of the people thinking that we look at malocclusion and facial malformations as a singular or dominated genetic situation. But after all, even in the textbooks, we say there is a multifactorial origin. So not only the genes, but all the other factors, including the environmental factors, are playing a role in the development of the problem that we see. So this is the same for the relapse. So there are not only genetical patterns in the relapse, but all the other multifactorial situations. But yet, in the everyday practice, if we look at how we treat patients based on the structural approach, based on the principle that it does not relate to any environmental factors, muscles, breathing, tongue posture, but we use this as an excuse. So when we fail, we use excuse as an excuse that, oh yeah, it was multifactorial. So it is we don't use multifactorial principle as it should be used. So what do we think about teamwork and the relationship of malocclusion and the treatment to the entire body? So we claim that malocclusion is isolated, and we do is what happens in Las Vegas, it remains in Las Vegas. So what we do it in the stomatognatic system, it does not have any effect on the entire body. There is a contradiction. So if I look at this, so if I use this publication from 2012, and it investigated the effect of cervical headgear on the cranial base, and it says very significant changes took place on the cranial base. So it is not so distant effect, but very significant. So it is not only as effect on the maxillary and mandibular position, but much more disturbingly on the cranial base. So we should not say we do not have any effect further than the maxillary mandibular dentition and deposition. And if we conclude, I repeat again, this is maybe people will find it provocative, but I would say, in order to highlight the problem, this is really, as it seems from an outsider perspective. Just look at the patient's perspective. It's like you go one orthodontist and the diagnostics and the treatment plan is one or A, and you will find B, C, D, very, very different and contradictory opinions. So we form clubs. We have gurus that we follow, or academic schools. We create results which are unstable unless we put retainers lifelong in the mouth. There are multiple opinions from the same practice, and we don't have best practice as we believe that we should have. And so the treatment plans are dependent which orthodontist we visit. So from the patient perspective, it is very disturbing. And we definitely sacrifice teeth and jaws for treatments that bring more harm and more risk to the patient than the lack of the treatment would. And this is something that makes me, at least, believe that that we call it a freedom on the one hand, but I think this is something that we should not call an evidence-based science, because if everything is possible, nothing is evidence-based. And then this is time to figure out what is the reason why we cannot find the answer in a subsystem for this kind of ongoing questions: extraction, non-extraction, early treatment, and so. And from that perspective, if we look at the debates, so there is a kind of aligner war. So aligner is very recent. Align Tech stated that the orthodontic braces are not needed anymore, which induced outrage in the specialty. But general dentists are taking a huge role in orthodontic treatments on the market. There is a claim that industry is taking the education, misleading professional opinions, and people are learning not from the academic schools anymore, or not only, but from the study groups. And non-extraction, early treatment, myofunctional orthodontics are all over-debated areas still. And the sleep medical invitation that we should take place in sleep treatments are rejected because we claim that it is not related to the jaws and the teeth. So so there are many questions, big questions that are present in the orthodontic specialty. And again, so how should we protect ourselves? And the best protection would be to have an evidence-based orthodontics that say, this is the science, this it protects and it supports the idea what we have. So it seems that people from the conventional treatment, they go more for cosmetic. From fixed bases, they go to aligners. So we seemingly lose a big market share as an orthodontic profession, because we cannot protect the job what we do as a specialist, which part is more professional compared to the one done by non-orthodontists with aligners, for instance. And yes, aligners will bring other challenges. Of course, Smile Direct Club went away from the market, but we should not be naive enough not to think that a new challenger will come to the market soon. So instead of protecting us by protests from direct to us customer aligner or mark companies, we should figure out why orthodontics is different, why the performed treatment by an orthodontic specialist is different from non-orthodontist. So I would like to introduce the new paradigm. So the one that should help us to understand the difference between different orthodontic treatments. So, of course, I would like to get back again. The birth of orthodontics was in the 19th, and in the same area, in the same time, the Western medical education and the practice changed by this very historical report, the Flexner report. So we introduced allopathic medicine that works with pharmacological agents and physical interventions. So we became a very materialistic practice of healing. So we believe that the human body is like a working machine, and the parts can be separated from each other. And we try to measure everything in order to decide whether it is necessary to treat or not. So in this perspective, this is very well understood why we talk about mal relationship. We measure structural forms, and we say that the craniofacial part of the human body can be separated from the entire other part of the human body. So we are structural, we treat malformation, we look at the problems as isolated, and we believe that the major cause of the problem is by DNA. But since this time, so we are talking about the early 90s. So since that time, there are so many different novelties, not only in the orthodontic specialty, but in medicine in general. So instead of genetics or within genetics, we are talking about epigenetics. So the growing power of environment. We have technological novelties. There are new techniques. There is definitely a different patient attitude. There are economical changes and changes in medicine. I mean, new medical approaches, functional medicine, integrated medicine, biologic medicine. So there are medical approaches that look at the human body as one. And neuroscience brought so many information. Basic science, anatomy, physiology gave us answer to questions that induces basic teachings to be rethought. And sleep medicine I think it is very important to dentistry in general and fascia research, and we just continue this list. So there are so many different novelties that induces changes, induces at least to step back and look at the problem, what we treat from a different perspective. I bring the genetic epigenetic debate again. So this is huge. So instead of the human genome study that we believe that would give us the answer and bring the answer, so we now talk more about the environmental effect on genes and the effect of genes. So it is not surprising that almost in every chronic disease, we talk about multifactorial origin. So, there is a congenital cause, of course, but there are environmental factors, and environmental factors in general, in just a broader scope and the closer scope. So, like in the orthodontic specialty perspective, lips, tongue, functions, head position, neck muscle functions. So all these functions will induce and play a role in the development of malformations and malocclusion. So this is the reason. So of course we believed when we formed medicine and we just went specialty into specialty. So we hope that there are subsystems with general rules. So we can believe that cephalometric analysis will give us the answer for having some understanding of the subsystem. But the systems are not isolated. So these systems are working together, so they are independent on each other. So this is the reason why we cannot answer, even though we try to make surveys studies, but we cannot separate the influence of the environment on the malocclusions and malformations. And sleep medicine brought a very interesting perspective, because sleep medicine is one of the medical approaches, the Western medical approaches, that are based on team, because of course the sleep physician is the main, the head of the team, but ENTs, psychologists, dentists, myofunctional therapists are also playing in this team. So it is not a unidisciplinary manner, but this is a multifactorial. The sleep is multifactorial, so the sleep medicine is accepting this kind of origin and addresses on a interdisciplinary manner. So yes, there is a huge amount of evidence that dental sleep medicine can help and can play a role in the treatment of sleep apnea and snoring. So it makes sense that the sleep medicine started to approach dentistry, and of course sleep is much more important than malocclusion. So you cannot die in a malocclusion, but you can die in a long-term sleep disorder. So sleep dentistry is an important part of the sleep physician team, and when we use these kind of principles in general in dentistry and in orthodontics, it will induces some changes in treatment direction, in appliance use. So definitely, when we accept that sleep is an important part of health in general and in medicine, so we should address these kind of requirements from sleep in dentistry and in orthodontics from sleep. But what is going on? So if we again, so sleep medicine is very integrative, the way that we accept that this is a multifactorial problem and we should address it in a multilateral way. But when we talk about sleep, we ultimately talk about general health, because as soon as we open airways, make the patient breath better, we improve the sleep quality. Of course, the patient's regeneration will be better. The patient's coping mechanism with any chronic disease will be better. So ultimately, we are improving general health. So this is very important, because not even in sleep dentistry, but in sleep team in general, we have to understand that it is not about airway size, but we are responsible for the general health of the patient. So this is important, because we are DMDs, we are DDS, but now it's making sense that oh, this is why we are doctors. This is why we are more responsible for the patient rather than giving a nice smile. But of course, I don't want to make it minor. So it is very important to give nice smiles to the patient. But I would like to emphasize that it can bring even more than just a nice smile. And when it comes to the medical approach, this is a medical approach, we have to look at the patient's right. So the medical ethic code by the American Medical Association. So the elective treatment, and orthodontics is an elective treatment, should be based on appropriate information. So the physician's obligation is to present the medical facts accurately to the patient, and the patient's right and responsibility to make a decision. So this is very important, because if we understand that some of the treatments that we proposed in the past or proposed in a moment bring higher risk to the patient than the lack of the treatment, this is something very important that we should consider or reconsider, how we force the patient, for instance, how we threaten the patients with potential consequences that are not supported by evidence. So the new doctrine should be based on accepting the fact that it is an elective medical intervention. The patient must be given options. We should highlight the risks and benefits. taking into consideration that malocclusion is not pathology, except for many few cases. And we are, as a medical doctor, we are responsible for the information what we have. This is medically, ethically important. So if we are aware of the fact that this is a multifactorial disease, not only genetics, we as we start communicating with the patient that it is genetic, so this is breaching the medical ethics. So this is very, very important. And based on these kind of features, if we rethink the definition of the orthodontic specialty, of course, we work with appliances. We are the oldest specialty of dentistry. There is something that we can be proud of. And we are moving teeth and bones. That's fine. We use forces and appliances to change the dental situation and the skeletal situation. But the second chapter is, I think it's very important. So this was not present in the 1900. So of course, this is new what took place all over the history of the orthodontic profession. So this is an elective medical treatment. As a medical doctors, we are responsible for the information. So we have to inform the patient about the multifactorial origin, and we have to present treatment alternatives, highlighting the risks of the treatment and the risk of the lack of the treatment. And certainly the risk of the treatment should not overcome the risk of the lack of the treatment, except for the situation when the patient, given all the information, makes this decision. Of course, in plastic surgery, it can happen all the time, but it should be based on information which is given to the patient. So we do not have right to threat the patient. The objective. So in the past, we made categories based on treatment appliance. So there is removal appliance orthodontics, fixed appliance orthodontics, visible, invisible. In the past, we differentiated pediatric orthodontics from adult orthodontics, but now we can differentiate orthodontic treatments based on the treatment objective. So now we can say that there are different type of orthodontic treatments. So in order to introduce different treatment categories based on the objective of treatment, we have to make a small list of the potential objectives. So certainly we can improve smile and facial aesthetics, we can improve mastications, we can improve periodontal health, and we can prepare the dentition for restoration. But I propose to put improving the general health into the objectives, because now we understand that we have a certain role in improving or worsening the general health, of course. So based on this, there are three major categories. So there is +1, the limited treatment for prosthodontics and periortho. But the three major categories are cosmetic treatments, full mouth restoration based on structural norms. So this is, I call the conventional contemporary orthodontics. So we measure norms, either it is hard tissue like bone and teeth and soft tissue, but we try to base our treatment on structural norms. But the third major category is health-centered and functional focused. So this is the new treatment category that I would like to introduce, which is based on how I can improve the health the most, and how can I avoid the effects, local and distant side effects the most. So this is the new treatment paradigm that I introduced. This is the functional health-centric orthodontic paradigm that try to achieve nice smile, of course, but as much positive general health effect as possible and the least amount of side effect. So this is a full mouth orthodontic treatment with maximized positive effect on the general health and with minimized side effect locally and on a distance level. We can qualify functional or health center functional orthodontics by treatment directions. So airway centric opening the maxilla as much as we can, moving the jaw forward, as the lower jaw as much as possible to open up the airway. Uses the lightest forces possible to reduce the local side effects, the least obstructive appliance possible for improving the oral function, the tongue posture, even during the treatment, using all the very rich proprioceptional reflexes, neurological reflexes around the stomatognostic system, and we cannot achieve health improvement without collaborating with other specialists in our professions. And certainly this is a kind of a lifestyle change, or kind of practice in which the patient has a certain role. So this is a paradigm shift that I induce, I have been suggesting for years, different forums, in order to understand that the arrival of the sleep and the importance of sleep, we can define now a new treatment category based on the treatment objectives. So formerly it was the angle area. Then by Dr. Sarver and Ackermann, we started to take pay more attention on the soft tissues around the 20 to 25, 6, 13. And then now the functional health centered paradigm arrives, and we should accept that this is a new possibility that we can provide to the patient. So these are the three major categories in the orthodontic specialty right now. And I think it is very important to place the fundamental foundation of a new approach. And the last part is how we should bring this kind of new type of orthodontic specialty into collaborating teamwork. And I just repeat again, so with the functional health-centric orthodontics, we want to achieve the most positive benefit possible and the least side effect. So how can we integrate in the collaborating teamwork? And in order to highlight this, I would like to get back. So as a Western medical doctor, we are trained as a specialist to look at the problems on a narrow focus. So we need to step back. And so I suggest the inside out instead of the inside out, the outside in approach. So I would like to ask us to step back a little and just look at what we do as a collective, collaborative team of different specialists on the craniofacial area, and look at how we can define what we do. So instead of inside out, so I would like to go outside in. So in order to define the name and the objective of the craniofacial collaborative work, I would like to start defining what health is. So health is a dynamic, balanced state. So this is not a status; it is just a process. And as a process, we are aiming for the balance. So this is very important. So we are talking about health as a balance. So we need to improve or increase the balance of the patient. So so I use this analogy in my conversations with patients and professionals that we look at the body as a battery, and we like to recharge it and fight with ongoing processes and increase the capacity of compensation. And when we talk about ongoing debates about tooth extraction and all the other interventions and their side effect, of course, it is not an isolated system. So many patients who are well with orthodontic treatment performed by tooth extraction, so they are doing great until the end of the life. So they don't develop any kind of side effects. And with the very same treatment, very same individual will develop side effects. So this is coming from a different places. So this is why all the studies that are trying to figure out the effectiveness of local treatment will not find the answer, because the ultimate consequence, the ultimate response from the body is defined by other features as well, the environment and the capacity of the patient's compensation. So this is why we need to look at the human body as a battery, so as a capacity of compensation. So this is compensation capacity. So this is how I look at, and there are many ideas and theories of compensation capacities in medicine. So so ultimately, we are working on the general health, general compensation of the body. So in order to make, like, for instance, an extraction therapy successful and non-symptomatic in the future, we need to support the patient's compensation. And we don't have to invent the wheel from the sketch, because definitely this is what functional medicine is doing. So we can approach functional medicine because this is the type of medicine that looks at the human body as a whole and does not treat the symptoms only. So so what is functional medicine? Functional medicine is an approach that that tries to look at the human body's processes as a collective. So the sleep, the diet, the stress, the hormones, and everything from the general perspective, not symptomatic perspective, but the entire body, and looking at the environment, lifestyle, and everything. So so we don't have to approach the process again. In general, there are 4 pillars of functional medicine: the structural body balance, the psychosocial balance, nutrition and detox, and environment. Why I use this? Because we will be able to apply orthodontics and functional collaborative teamwork into this map, for instance. So what is the missing link? So what do we need more? And a definition of something that we call craniofacial functional teamwork. So so if we start collaborating, to the orthodontist, the functional orthodontist, functional dentist, we start collaborating with an ENT, with an orofacial functional therapist, the breathing specialist, the body worker. So ultimately, we will work on the health of the patient. So there is no local health; there is only global health, and this is the work that we ultimately work together with this kind of specialists. So in order to create this kind of missing link, we need to make a definition of craniofacial teamwork, and this is so collaborative functional medical teamwork is functional teamwork that ultimately supports the general health of the patient from the craniofacial perspective. So so this is quite simple, but we have to create this kind of missing link in order to put everything into the same map. So if we say functional medicine is aiming for the general health of the patient by looking at all the pillars of functional medicine and fixing those missing elements from the body balance perspective, from the psychosocial perspective, from the environmental perspective, from the detox and nutrition perspective. So this is the job into which we can integrate the craniofacial collaborative teamwork of dentists, OMTs, ENTs, speech therapists, and body workers that work on the cervical body as well. And definitely that type of orthodontic specialty that aims for health in general, the functional health and the functional orthodontist, is going to be part of this. So I think it is very important to put everything onto the same map, to understand that, yes, there is orthodontics categorization based on appliances, based on age, but now based on objectives as well. So and there is going to be a different type of orthodontics that that not only works on the craniofacial structures, but it works on the functions, and the principle, the why, is going to be this: one health, one goal, one medicine. So in the future, not only the conventional structure-based orthodontic treatment will exist, not only the cosmetic orthodontics will thrive and go further with aligners, but there is going to be a new health center functional, sorry, the line has just dropped down into a different category, but this is the blue, the light blue arrow represents the health center functional orthodontic specialty. And I use this map, just finally, to put all these treatment modalities onto this map to develop teamworks. So on the body part, you can work with the body components, the muscle strength, the breathing, the craniofacial function, and of course, changing the structures can be part of it. But now we have the map. We're working with the functional neurology, with stress, with traumas, and with communities. So I use as a map for just a like a map to put team components, team specialists into one team to achieve the goals. So I think this is the time to change the focus from materialism to functionalism, and to deeply specialized medicine to integration. So now the pendulum changed this way, and then we are going further integration. And in order to be able to answer the whys and hows, why we do what we do, we have to step back, and the future of medicine is going to be more patient dependence, participatory, more functional, more preventive or proactive, and hopefully there is going to be affordable version of it, and certainly integrative. So this is why I find important to reestablish a new type of orthodontics and a new type of name for the collaborative teamwork, what we do on a craniofacial functional work, because it makes more sense for the patients, and it makes more sense for the practitioners, and it gives us a new perspective in the future. So thank you for your attention, and thank you for the invitation again.
Thank you for your contribution, for your approach. Is a new ortho approach and on functional medicine. Thank you so much, Dr. Hermann. Thank you.
Thank you. Thank you.